reactive attachment disorder, there has been a change. And I know people would be interested because a lot of you have cases that involve this. In DSM-4, there were two types of reactive attachment disorder. There was the inhibited type and the disinhibited type. What DSM-5 has done is extracted the disinhibited type from reactive attachment disorder. It's only the inhibited type. Because what they discovered in their trials, field trials, etc., was that the internalizing disorder, there were two. The reactive attachment disorder, the formerly inhibited type, is essentially an internalizing disorder. That the disinhibited type, and that was the type that would run all over and start touching you, and they hardly know you. That was also the type that would act out a lot, the type that might spread feces all over the place, and parents would come in and say, what are we dealing with here? Or what, they've adopted a child and this is what we got, or they're guardians of a child in the family that everybody's had difficulty with. So it's switched. And there's a little bit of a reconceptualization that the disinhibited type, which is now the disinhibited social engagement disorder, is a boundary violations, that there's no boundaries for those kids. Cause is the same. So it's just, they're kids who have been neglected in terms of their care, or they've been abused. They're just not getting their basic needs met at the very minimum. So we've known that all along. So here's the reactive attachment disorder, exactly what the old criteria was almost: not receiving comfort from contact with others, persistent social emotional disturbance, they're minimally social and emotionally responsive, limited positive affect, unexplained irritability, sadness, or fearfulness evident during non-threatening interactions with caregivers. Pretty much the same, right? The duration has to be greater than a year. It's severe if all the symptoms are present, and all the symptoms are present at high levels. But the prognosis for this is positive. What they found in the years that they studied was that kids who were put in nurturing environments could make a healthy attachment. And that when they followed these kids up into adolescence, they didn't have the disorder in adolescence. So they actually could resolve with proper care. The disinhibited social engagement disorder, however, did not resolve. That continued. They found plenty of kids in adolescence still with the disorder, and the trajectory here isn't a real positive one. It's long established relational patterns that are highly problematic and ingrained, and may then be associated with later onset personality disorders, essentially. So they're going in two different places. But the other criteria is the same as it was in DSM, 4TR, overly familiar with strangers, loose boundaries, doesn't check back with caregiver. All of that is really the same thing. And the same cause. They do indicate that children for this diagnosis have to have a developmental level of at least 9 months of age. Okay. Did you have a question? No? Okay. You're on adjustment to, okay, I'm going to switch to child things. You mean to tell me she's hiding behind her hands? I'm going to go to feeding and eating disorders. I told you before that all of them are now under, all the disorders that were early childhood things are now within the same feeding and eating. You might note that binge eating disorders, which was in the appendix in DSM-4TR, is now a recognized diagnosis. So many times you had to diagnose mood disorder when you knew you had a compulsive overeater, and you'd say this really is a disorder. The criteria, look, they were the same criteria that was in the appendix is now for the binge eating disorder. For anorexia, these are the changes. They have removed the criteria of amenorrhea, missing 3 consecutive periods. That is really good because now we can diagnose men as having anorexia nervosa. And We've never, I mean, really, there are a lot of males with anorexia, and since they don't have periods, they don't have amenorrhea, and they would never want to have either one. So they also changed the wording a bit to restriction of energy intake relative to need. So there wasn't so much concentration on food and calories and better. The weight, the significantly low weight, was defined as weight that is less than minimally normal for adults or less than minimally expected for children and adolescents, so it's kind of loose. Severity would be based on body mass index. So they don't do that percentage anymore, less than 85% of their body weight, they don't. It takes away arguing over that pound that they, you know what they're like. Bulimia nervosa, the required minimum frequency of binge eating and purging is reduced from 2 times a week to 1 time a week to catch this earlier. The binge eating and the purging, that's really dangerous, and they use all those crazy things to get food out, and dangerous things happen. So want to get it faster. The severity would be based on the number of episodes of compensatory behaviors in a week. And then there are some criteria given for remissions. Another change. If you've worked with eating disorders over time, you know that they don't stay in the same place. They don't. So it's not unusual for somebody with anorexia to cross over and become bulimic. It's not unusual for somebody with bulimia nervosa to cross over and become a binge eating disorder. It doesn't remain in one category. So now what you do is look at during the last 3 months. What are they doing during the last 3 months? Has not engaged in recurrent episodes of binge eating and purging. Okay, that would be the restricting type. Binge eating, purging. During the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging. Severity would be based on the body mass index percentiles, but can increase to reflect the other symptoms. And we do look at the other symptoms. The need for supervision to eat, the need for supervision to have healthy exercise or minimal exercise or none, and the degree of impairment and functioning. They have one for partial remission. Low weight criteria not met, but the presence of other symptoms are still there. This is the same as was in your appendix in conditions for further study in DSM 4TR. So same thing, recurrent episodes of binge eating once a week for more than 3 months, 3 of the following: eating much more rapidly than normal, eating until uncomfortable, large amounts of food when not hungry, eating alone because of embarrassment about how much one is eating, feeling disgusted, depressed, guilty, but no compensatory behavior. They don't diet, they don't purge, they don't use laxatives, they don't do anything like that. The severity of this would be based on the number of binge eating episodes that they engage in per week. And then there are some NOS. Since NOS was eliminated, there are some other specified feeding or eating disorders, like the atypical anorexia. If you've got an individual whom it's all the criteria, but their weight is within or above normal, that can happen. Bulimia nervosa of low frequency and or limited duration. Binge eating disorder of low frequency or limited duration. Purging disorder, and it does say purging disorder, but if you look in the back, it's not a separate disorder. It's just purging disorder. Purging in the absence of binging to lose weight or shape. And in the middle-aged population, middle-aged women do a lot of unusual other specified feeding and eating disorders, so that would be one of them. Then another change, the night eating syndrome. You probably have heard of patients or had patients whose physician told them, well, you're eating, that's why you're not losing weight, you're eating at night. And then the patient will tell you, I don't eat at night, and my doctor told me, I'm probably eating in my sleep, and how can I eat in my sleep? There is a sleep disorder where they do eat at night, and they have no recollection. But this is different. This is an eating disorder. These are people who do get up at night, they eat at night, but in the morning they have full awareness but that's what they did, and they can recall the details. So it's not a sleep disorder. Intermittent explosive disorder. Dear Santa, please bring me what I want for Christmas. Prancer and Dancer are next. So the disruptive impulse control and conduct disorder include these, which I mentioned this morning. Oppositional defiant. There are not a lot of changes to the criteria, but they group them differently. So some of the symptom presentations are grouped by behaviors, the argumentative defiance, by emotions, angry, irritable mood, or by vindictiveness. They're grouped this way because the treatment is different and the fluidity of diagnosis is different. For example, the treatment of the argumentative defiant behavior is often parent training and a little anger management sometimes, depending on the age of the child. Anger management for the kid, parent training for the adult. If you've got angry and irritable mood, note that you need to do a little bit of treatment for the child for mood issues and for emotion regulation. If you have symptoms that are in the vindictive area, note that this is a different trajectory. This is more the move into conduct disorder, and treatment would be very different. Okay? So this has been added. Symptoms must be observed toward others who are not siblings and fall outside a range that is normative for developmental level, gender, and culture. So you may think of some siblings that you had, and you may think, oh, wow, they acted this way toward me. Okay, normative. I also want to caution that we need to be careful not to just assume that just because they're siblings, it isn't abusive behavior. There's a lot of sibling abuse. So we need to, check that out first. Specifiers for severity have been added, mild, moderate, severe. They've been based on the number of settings in which the symptoms are present. And this is a new change. You can diagnose oppositional defiant and conduct disorder together. Remember, your training was probably the same as mine. I think this one works. Where what we learned is we had stubborn behavior first, and then we had the diagnosis of oppositional defiant. If that went untreated and things worsened, that would have moved into conduct disorder. Then, if that was not treated successfully, and after the age of 18, the person also showed a lot of irresponsible behavior, that would have moved into antisocial personality disorder, right? So we learned that that was a trajectory. What we also were told is if you're dealing with a child who meets criteria for both oppositional defiant and conduct disorder, you wouldn't diagnose oppositional defiant, right? You just diagnose conduct disorder, because we would figure, oh, they've already passed through this, and conduct disorder would supersede. At first I wondered, why are they doing this? Why do they allow this? It wasn't making sense to me, but then when I looked at it and I looked at the research, it does. There are children that bypass oppositional defiant altogether. They never met criteria. They go immediately to conduct disorder. So think about the people you've known. If some of you have ever worked in juvenile justice, you can have a 5-year-old who meets criteria for conduct disorder. And there wasn't the argumentative stuff. It was conduct disordered behavior immediately. This is a different trajectory. So when you see a diagnosis with this together, there's a more positive prognosis and not quite as difficult treatment. If you don't see this plus this, if you only see that, more difficult trajectory, more difficult treatment. So that's why they allow both. They also did include the specifier. Changed the name. When we presented before, there was the specifier was called with callous and the callous and unemotional specifier for conduct disorder, which a lot of people had objection to and said that's very harsh. to put that specifier on a child, my gosh. Well, this one isn't quite as bad, but it's still not a good thing. So with limited pro-social emotions sounds better. But to qualify, the child must have displayed at least 2 of the following characteristics persistently over at least 12 months and in multiple relations and settings. I like the idea of in multiple relations and settings for children if we're going to use a serious diagnosis of conduct disorder, because children are different with different people. They can be very conduct disordered with one teacher and not with another, very conduct disordered with one parent and not with the other. So multiple situations and multiple relationships. The rub is that we then have to get information from multiple sources. So parents, teachers, sibs, peers, aunt, uncle, multiple sources. To qualify for the specifier, in all these multiple settings and with multiple people, there needs to be a lack of remorse or guilt, a callousness, a lack of empathy, being unconcerned about his or her impact on others, even when it results in substantial harm to other people, unconcerned about their performance at school, work, or other activity, shallow or deficient affect, just that they're using emotions to manipulate the situation. A rationale for that. I don't know how you all feel about it. Most people, when I do a presentation like this, they're very uncomfortable with this specifier, except for when I went to the juvenile justice system, and a place in Harrisburg, their prison system in Harrisburg, and they were all like, yeah, sure. So maybe you've seen kids like this, maybe not, but you look at the psychopathology, the 3 traits, behavioral things that are aggressive and destructive, emotion, the lack of empathy, and interpersonal manipulation, using others for your own gain. The most serious is this one. The research really is based on 20 years of research with children. So I'm going to tell you how they found the difference. And they wired kids, they gave them EEGs. So they had the electrodes in their brains, and they showed them very graphic pictures of people being tortured or something, burned, very difficult things. So imagine yourself wired up and being shown these pictures. What do you think would happen with your EEGs? Do you think there would be reactivity? Yeah. Sweat response, a lot of like upset. These kids, flat, nothing, no. Yeah, it is scary. So really, the callous and unemotional predictor it's really predictive of severe and prolonged antisocial psychopathology. So I don't know if you have questions or reactions about that. No. The intermittent explosive disorder, they've redefined it a little bit, frequency twice a week on the average of 3 months. Here's what they've changed. If there's without damage to people, animals, or property, twice a week on the average of for at least 3 months. If there are damages to people and property, the frequency is 3 times in a year. Very much like conduct disorder. We used to have that. The aggressive outbursts are not premeditated. There's no direction. It's pure emotion. There's not a goal, a manipulation. It's just a blast of anger, and it causes distress to the person who has the intermittent explosive disorder. They have very much distress. They lose friends. They have financial problems or something else. Have to be at least 6 years old, again, because of temper tantrums and rages and difficulty with emotional regulation that occurs under 6, or the developmental equivalent if we're talking about a challenged individual, or ruling out aggressive behavior that may occur during an adjustment disorder. Sometimes there are serious adjustment issues to a specific situation, and you know, the children are reacting quite a bit, and it would not qualify for intermittent explosive disorder. If, again, if criteria is met for the disruptive mood dysregulation disorder, it would supersede this diagnosis of intermittent explosive. So then I said, no, this little piggy is going to the bar. Okay, I'll go to gender dysphoria. We're not going to the bar. Stan is going to take you to the bar later.
We'll go to the bar later.
Yeah. He's going to take you to the bar. I'm going to finish up on my last thing. Gender. This was a huge hotbed, by the way. Do you remember, was it gender identity disorder? Okay. Well, think about your identity according to your gender. What all goes into that? Your heritage, your relationship with your mom and your dad, what you were exposed to, your religion might go into it, a lot of things. So when somebody says your gender is disordered, pretty much, your whole identity is disordered, it was very insulting. So the people who specialized with this were just furious, and were really hoping that there would be something more accurate in the DSM-5. So they have made adjustments. I presented at Live Oaks and some of the other places that specialize, and it's still not good enough. It's still not good enough. But they say that it's gender dysphoria is the new name, and it's really the incongruence that you experience between one's experienced or expressed gender and one's assigned gender. Your assignment is what you're assigned to at birth, okay, as either male or female. And that's true of our society. What I learned, however, is very interesting. In European countries, they recognize five genders. We come and we get a job application and you check off male or female. It's not true. It hasn't been true in Europe for a long time. They recognize that gender is on a continuum too. And then I read further, and there are some tribal areas where there are 28 different genders, which is really details on the continuum. So what they've said is it's the dysphoria that accompanies, and they've also changed it, well, to the other, like the other gender. They recognize that there are more than, we have a binary society, unfortunately, but in DSM-5 there's a recognition that that isn't really true. The unfortunate part here that people don't like is the dysphoria creates the impression that somehow this is the responsibility and fault of the individual. Yeah, when it's really, it's a social problem. So while they dealt so well with so many contextual factors in many of the other diagnoses, they did not deal well with a contextual factor with this. So it can be diagnosed in kids. If it causes significant distress, this has been a gender identity eliminated. Gender nonconformity, we know that's not a mental disorder. Instead of the wording, the other sex, it's some alternative gender that's used in DSM-5. So it's a lot better. For kids, the focus is really on wanting to be of the other alternative or alternative, but toys, wanting to use the toys of another gender, wanting to dress like the other gender. So it's preference for gender roles, wearing clothes, the toys, the games, the dislike of their anatomy, and some of the desire to have the characteristics of their experienced gender. And it may also have, some of them have a disorder of sexual development with it, a physical issue with it. And then we would code it and specify, that would be a specifier. Okay. In adolescents and adults, exactly what you would think would be the focus. The discrepancy is here between the sex characteristics or anticipated ones. if they wish that they were born in a different body, and they're thinking the body I'm born in is going to develop boobs and I don't want that, ugh, you know, they'll go to extreme extents to get rid of, unfortunately, they go to extreme to get rid of them, to bind them down, to cut them off, to do things so that they can feel a sense of congruence between who they are and what they're wrapped in, if, you know, for lack of a better thing. So strong desire to be the other or the alternative gender, strong desire to be treated as the other, strong conviction that they have the typical feelings of an alternative gender. And again, if it's associated with some kind of a medical issue in sexual development, you code it. You also specify if it's during the post-transitional period, if they are living full-time as the desired gender and they're undergoing or preparing for at least one cross-sex medical procedure. I did have one thing to say about. Can I say one more thing?
Say one more thing.
Okay. Some of the justification that the task force came through with is that they felt like, okay, they had to give a diagnosis for this because you can't get treatment. And a lot of these people need treatment. So they're hoping that the gender dysphoria will provide some insurance coverage for people who want to go through the procedures. So there is a little bit of justification. There's also problems with, I mean, this is one where 2 committee members marched out. If anybody followed the DSM-5, they left. One of the members in the task force believed in conversion therapy. It was a nightmare if you followed that. Yeah.
If you say, for example, we had the experience of a child who was born with ambiguous sex organs and was assigned a sex
By the parents.
by the parents.
Mm-hmm.
I'm just wondering, does that
You would
medical
indicate.
trump?
No, you would indicate that under what's associated, the medical or the problem in sexual
Okay.
development. That's where you would put it.
as
Yeah.
a specific?
Yeah, thank you for saying that. That's important.
Okay, Susan has to leave and go to her practice now. I want to say a couple things. One of them is something that's a pretty important change, adjustment disorders. Adjustment disorders, the criteria are identical to what they were before. The way it's conceptualized, though, is very different. You know, the way that we're thinking about adjustment disorders, you kind of rule out everything else. If there's a clinically significant condition and there's a stressor, then we diagnose adjustment disorders. DSM-5 says that this can be a potentially fairly serious diagnosis. So, for example, suppose that you have someone who is exposed to a traumatic event, but they don't meet the full symptom criteria for PTSD. You would diagnose an adjustment disorder. Or suppose that you had someone who has the full criteria for PTSD, but the event is bullying. Bullying that doesn't meet the definition of criteria for traumatic event, because we all know that sometimes it can. You would diagnose an adjustment disorder. The problem is going to be us. You know, some of us in here like me have over 35 years of thinking about an adjustment disorder as just kind of a residual category that we get to. DSM-5 is thinking of it as potentially much more serious than that, even though the criteria don't change. They're exactly what they were in DSM-4. So what's going to happen in terms of billing and coding and all that, that still remains to be seen. But just be aware that the way that we think about adjustment disorder in DSM-5 is a bit different. Now, addictive disorders, substance use and addictive disorders. Here's what's in here. Notice gambling has been moved into this section. There was a proposal to have internet gaming disorder and fetal alcohol syndrome. They didn't make it in there, and they're in section 3. Caffeine use disorder, internet gaming, neurobehavioral disorder associated with prenatal alcohol exposure, FAS in other words, are all in section 3. The big thing is that they collapsed abuse and dependence into a single diagnosis of use disorder. Remember, we had 7 symptoms for dependence and 4 symptoms for abuse, and they weren't the same symptoms. So the question I used to ask is, so what happens if you have 2 dependents, a clinically significant substance use problem, and there are 2 dependent symptoms and no abuse symptoms? What do you diagnose? Nothing. That's a trick question. You don't diagnose anything because you have to have 3 dependent symptoms to diagnose dependence. Only 1 abuse symptom is required to diagnose abuse, but they're not the same symptoms, which was foolish from the beginning. What they've done is they've collapsed these into a single diagnosis of alcohol use disorder, cocaine use disorder, and then we specify severity depending on how many symptoms are there. So if we have 2 or 3 symptoms, we diagnose substance use disorder mild, 4 to 5 is moderate, and 6 or more is severe. So it's one term and levels of severity. They've added criteria for cannabis withdrawal. And again, gambling was moved into this section. 10 separate classes. The classes basically the same, except they've changed the name from nicotine to tobacco. In one of those great moments of diagnostic irony, now people are using electronic cigarettes, so in fact it is nicotine and not tobacco. Oh, good. Polysubstance dependence is eliminated. Remember, it used to be if you had people that had like alcohol dependence disorder and cocaine dependence disorder, marijuana abuse disorder, you would diagnose polysubstance dependence. Now you diagnose each one of them separately. So you diagnose the use disorder and specify level of severity for each one. Addiction is not used now and hasn't been in DSM. Now, the problematic pattern of use leading to clinically significant impairment of distress for at least 2, not 3, of the following. And the symptoms are exactly the same as they were before with a couple exceptions. They've added craving as a symptom. So craving or strong desire to use whatever the substance is. And the other thing that they did was that they eliminated the legal problems criteria. Now the reason they said they did, it's because extremely low prevalence. What I would say is the legal problems criterion was always a difficulty because of the fact that whether or not you had met this criterion might depend on how old you are, where you lived, and what color your skin was. So if if you're an inner city kid living in inner city and you're an African American, if you get busted with pot, you might end up going to jail. If you're a white kid living in a rural area, the cop would probably slap you up the side of the head, dump your weed out, and then take you in to see your dad, and then you'd really be in trouble. But you wouldn't have a legal, any legal problem there. So anyway, that's what we do. 2 symptoms, same set of symptoms. They collapse the 2 together, so we have 11 symptoms now instead of 7 and 4. So basically that's all that's about. We still have specifiers for with and without physiological dependence. If you have tolerance or withdrawal, you have with physiological dependence, otherwise not. The symptoms are clustered. They don't do anything in terms of diagnosing with the cluster, but if you're explaining it to somebody, sometimes it's helpful if you number the clusters to talk about it that way. We still have early and sustained remission at 3 months remission and 12 months for sustained. Don't have any of the diagnostic criteria except for craving. They recognize that craving can last a long time, even after you're really in remission. We don't have any more partial remission that's there. What do? We just change the severity specifier. So if a person doesn't have as many symptoms, instead of saying partial remission, we would move it from, say, moderate or severe to mild. Okay, cannabis withdrawal. 3 or more of the following signs or symptoms develop within approximately 1 week. Irritability, anger, nervousness, anxiety, overwhelming urge to watch Cheech and Chong movies, that kind of stuff. What kind of tea is that? I don't know, man. I found it in my grandson's room. Okay, good. Okay. Okay, neurocognitive disorders. Now, let me say before I go to that, I'll go to the end and say that personality disorders, remember we talked about those new criteria? On December 1st, when they signed the final draft, they said, never mind, the personality disorder section is exactly what it is in DSM-4. No changes. Same disorders, same criteria, same definition. It's exactly the same as it was in DSM-4. So after all of that mishigas that was there before about, oh, what are we going to do and all that, never mind. So the personality disorder is the same as it was before. We just don't have axes. Doesn't mean that we don't have personality disorders. We just don't have a really a nice shorthand way to talk about our relatives anymore. So neurocognitive disorders, there's some fairly substantial changes to this section. First of all, what do we have in here? We have, there are 6 domains identified in the neurocognitive domains. Delirium is pretty much the same as it was before. Then we have major and mild neurocognitive disorders. We don't have a condition called dementia anymore. So, the major changes, the group was renamed from dementia, delirium amnestic, and other cognitive disorders. They're attributable to changes in brain structure, function, or chemistry, okay? And then you code the etiology. So if it's due to Alzheimer's disease, vascular disease, you know, traumatic brain injury is one of the etiologies. Dementia is subsumed under the newly named entity major neurocognitive disorder. Now, why did they do that? If you remember the diagnostic criteria in DSM-4, it requires impairment of memory plus one other impairment in one other domain. The problem is that some of the types of even what we were calling dementia don't necessarily have impaired memory. Either they might not have impaired memory ever, or they might not have impaired memory until a condition gets pretty severe. So where we especially found the problem was with traumatic brain injury. A lot of people with TBI, their memory's just fine. Other kinds of areas, they may have some serious impairment. Or people who have strokes, they may have their memory be okay, but they may not be able to speak or recognize words. So they have a major neurocognitive disorder. We've now added mild neurocognitive disorder, which is similar, the criteria are very similar to mild cognitive impairment, okay? So the domains of cognitive functioning, again, domains are not entirely independent, boundaries indistinct, variable definitions, but here's how they've defined it in DSM. First of all, complex attention, ability to sustain, divide selectively, you know, the multitasking, the things that my students are better at than me, but not as good at as they think they are, right? So complex attention, executive functioning, planning, decision making, responding to correction and error. Learning and memory is one of the domains, but it's not privileged above the others. Language, expressive, receptive language. Perceptual motors, visual, constructual, praxis, you know, recognizing objects. And then social cognition, theory of mind, recognition of emotions. Theory of mind is that thing that parents of adolescents, what were you thinking? That's a theory of mind question, okay? So those are the 6 domains. The definition of major neurocognitive disorder, significant cognitive decline, and that's important because this differentiates it from neurodevelopmental disorder. So it's decline from a previous level of functioning in one or more domains based on concern of the individual, knowledge informant, or someone like a clinician, that there's been a substantial, significant decline. Significant impairment in cognitive performance, preferably documented by standardized neuropsych testing. There was a lot of argument about that because they didn't want to require neuropsych testing to do this. Now, what I would tell you as both an aficionado as well as a clinician is that I would strongly recommend that if you can, get a baseline neuropsych evaluation. And here's the magic word, and we probably should delete this out of the tape, by the way. The magic word for your primary care doc is, I've been having problems with my memory, so that you can get a referral to a neuropsychologist to do the testing. The reason you want a good baseline is that future testing is really relative to what? So, for example, suppose I told you that, well, I saw a guy today that had an intelligence, an IQ of 105. Would anybody be concerned? No, because that's within normal limits, right? IQ, mean, and the average is 100. But suppose I told you that this was an MIT graduate who had started out with an IQ of 165. Now would you be concerned? Darn right we would. Now, having a baseline to know what you started with is going to be important in recognizing early clinical signs. Now, the current research on dementia suggests that the process leading to dementia starts somewhere in the neighborhood of 10 years before there are any clinical signs. A lot of the treatment approaches that are being considered are based on early intervention. So being able to identify, diagnose it, and get persons into treatment may at some point be important. Right now, not so much. You know, there's quite frankly, the research is equivocal on early intervention and what that means. What it looks like now, by the way, most of the stuff that I've seen in terms of treatment of symptoms of dementia is that if you look at impaired functioning, if you initiate treatment, that what happens is that the decline is slower, but once the decline starts, that it ends up matching the decline of somebody that's there that doesn't receive treatment. So that over time they come together. But my hunch is that when they start coming up with some stuff that really works, that getting to it early is going to be an important thing. Even now they say, you know, slowing down that decline is a pretty good thing. Cognitive deficits interfere with independent activities of daily living. So ADLs are not very sensitive to early onset of dementia. ADLs, you have to be pretty impaired before that starts getting impaired. Things like being able to manage finances and medications and stuff, that's more sensitive to beginning impairment. So they interfere such that the person has to have assistance in performing complex instrumental activities of daily living. So the difference between major and mild is, does the person require assistance? If they require assistance, then it's major. It doesn't include exclusively doing another disorder. Specifiers, according to presumed etiology, Alzheimer's disease, vascular disease, Lewy body dementia, etc., traumatic brain injury. Behavioral disturbance, this is what used to be called behavioral and psychological symptoms of dementia, or BPD. So the psychotic, mood disturbance, agitation, apathy, or without behavioral disturbance. And then specify level of severities according to how much impairment. Mild neurocognitive disorder, modest decline, and if you look at what they say in terms of standard deviations, 2 or more standard deviations in terms of decline, they're talking about major neurocognitive. 1/2 to 2 is mild neurocognitive disorder if you have testing. So modest decline. And the cognitive deficits don't interfere with a capacity for independence, but greater effort, compensatory strategies, or accommodation may be required. Okay? And then it's the same thing as before, you code the etiology. Okay? And these are the etiological factors, and they have a pretty good description, by the way, of characteristics of these different etiological factors. And what, by the way, we're finding out is that the Lewy body is a lot more prevalent than we used to think it was. Vascular disease and, of course, Alzheimer's disease, they overlap quite a bit. Prion disease, so that they have the etiology, and it can be multiple etiologies or unspecified. The sad thing about this, Joe, is in 70 years we'll be doing the same thing. She'll be bald, no teeth, and wearing diapers. Ah, dang it. Yeah, bless your heart there. Personality disorders, you know, same as before, no change. No matter how big and bad you are, when a 2-year hands you a toy phone, you answer it. Okay, I'm all done for today. Done enough damage for one day. So, thank you very much. That's all, folks.